improves clinical outcomes compared with optical medical therapy alone. Definition of vulnerable plaque based on imaging. Minimal lumen area less than 4 mm square by either IBIS or OCT guided. Plaque burden is more than 70% by IBIS. Thin cap fibroadenoma, the plaque should be there by radio frequency IBIS. So that is defined as more than 10% confluent necrotic gate core with more than 30% abducting the lumen in 3 consecutive frames of RF IBIS, or a lipid plaque with an arc more than 90 degree and a fibrous cap thickness less than 65 mm.
So NRIS for?
Near infrared spectroscopy. It is all these are imaging modalities, we will decide the plaque.
So these all are imaging.
These all are imaging.
So your CT coronary angio or MR angio will not use this thing, right?
So all image intervention.
IVAS के OCT અને NIRS કશું તો થયું જ હોવું.
Yes.
ચારે જોશે ને સાહેબ, આમાં તો ઓર નથી લખ્યું.
ઓર લખેલું છે ને બધે. ઓર OCT ઓર IVAS ઓર OCT.
ના પણ એ તો 1 2 3 4 તો ચારે 4 પોઈન્ટ જોશે કે 4 માંથી એક હોય તો ચારે 2 જોશે.
And third is NIRS with this lipid rich burden index we have to calculate. Mostly 4 mm maximum is calculated, which should be more than 3.5. So these are the criteria for defining vulnerable plaques based on coronary imaging. The inclusion criteria: men or women more than 18 years, patients with angiographically significant stenosis, that is more than 50%, with negative FFR. So more than 0.8, meeting two of the following, the 4 criteria: MLA less than 4 mm, plaque burden more than 70%, PCFA or LCBI more than 3.5. Eligible for PCI with absorbed BVS or EES. Reference vessel diameter should be 2.75 to 4, and lesion length should be at least less than 40.
So BBS ES
It's a bioresorbable vascular scaffold which had been started in the initial of the study. It was by Absorb and Abort company. Later on in the study it was stopped, so it was switched to everolimus eluting state. This was the inclusion criteria. Exclusion is a patient whom the preferred treatment is bypass, previously stented lesion or a bypass graft lesion, patient with 3 or more target lesions, patients with 2 target lesions in the same coronary artery, heavily calcified or angulated lesion or bifurcation lesion requiring 2 stent technique, and if there is any contraindication for discontinuation of dual antiplatelets within 1 year. Coming over to the procedure, prevent
Heavily calcified.
Heavily calcified won't, if the plaque itself is heavily calcified, it won't be vulnerable. It would be more like a chronic total occlusion. So there is no point in it. Open करना change things.
Heavily calcified का criteria define करो. Semi-heavily calcified.
It is a
Calcium score पर ठीक है.
Calcium score and MR lipid core content would not be more than 70%. जब plaque burden है से lipid core that won't be.
I was OCD માં easily ખબર પડી જાય.
IVAS OCT.
IVAS or OCT.
આમાં number of patient ને બધું આગળ આવશે.
Yes, I have. The procedure was it was done in 15 research hospitals in only these 4 countries. During initial recruitment period of the trial, PCIS was performed by BVS, which was from Abort, and following the withdrawal of BVS, cobalt chromium everolimus eluting metallic stent were used. Intravascular imaging of all the target lesions was performed. Patient received dual antiplatelet therapy for at least 6 or 12 months after PCI, according to the clinical presentation and analytical complexity. And follow-up was done at 1, 6, 12, and 24 months and 80 years thereafter. And follow-up continued annually in all enrolled patients until the last enrolled patient reached 2 years after randomization. This is just an example of the patient which was taken. It was based on the angiography showed diabetes stenosis of 70%, FFR was negative 0.83. Based on the imaging, these criteria were found: MLA 2.11, plaque burden was 79%. So, in that patient, this absorbed stenting was done. This was the initial the example. Coming over to the study design, any significant epicardial stenosis which is more than 50%, revascularization was needed, or unplanned hospitalization due to unstable or progressive injury. This was considered the primary endpoint.
So આ જનરલ પોપ્યુલેશન હતું કે કોઈ હાઈ રિસ્ક પોપ્યુલેશન હતું?
So general population they have
જનરલ પોપ્યુલેશન નથી એટલે
stable IHB they mentioned in the future. The OPD basis ne stable IHB because all the other characteristics does not specify any significant
પર્ટિક્યુલર કોહોર્ટ નહોતો.
no. Yes.
So there.
And again, mentioning the primary endpoint, target vessel failure. Its main thing is this: a composite of death from cardiac causes, target vessel MI, ischemia during target vessel revascularization, or hospitalization for unstable or progressive angina 2 years after randomization. Secondary points included all the individual components of the primary composite output, patient-oriented composite of all cause death, MI, or any repeat revascularization, procedure safety outcomes, stroke and bleeding events, and number of anti-anginal medications used at each point. The patients involved, so there were like 5627 patients with intermediate stenosis were found. So it started in September 2015 and ended in September 2021. So all those patients with having stable complaints and who had underwent coronary angiography, those who were found with stenosis more than 50% were line listed. Among them, only 3562 with lesions more than diameter stenosis more than 50% and negative FFR were considered, so that was 63%. Among them, only 1068 were found having imaging criteria of uneven. So of that also 45%. So total the subjects were 160 and 803 patients were preventive PCR plus medical therapy and another 800 for only medical. So total patients that were studied were 160.
So almost 40% qualified for vulnerable flex criteria. That's a huge number.
Yes. And going over to the follow-up part, in the preventive PCI plus OMT, 97% completed the follow-up, and all of them were included in intention to treat analysis, even if those who were lost to follow. And in similar count, in the medical therapy also 96% had completed 2-year follow-up. 1 or 2 patients were missed for 7-year follow-up, but the 97% was all 2-year follow-up वाले patients ने हिसाब से analysis किया. 7-year वाले मुझे पर अलग. The baseline characteristics, age, mean age was 64-65. In that, female ratio is less, only 25% or 29% females were included. Most maximum was considered for stable angina, 83%, and only 1% was ST elevation. EF was always normal, 60%, and that is all.
So જે પેશન્ટ ને ડિસ્લિપિડેમિયા નહોતું તે ઓલરેડી સ્ટેટિક પર હતા?
It is a yes. Now, it is a drug for actually specify nothing more. If I add individual drugs in
If you are having vulnerable flags and your lipids are normal without statin, it's little.
કોઈને બેઝલાઈન કેરેક્ટરિસ્ટિક્સ માં પર્સન્ટેજ વાઇઝ
બંનેમાં ગાઈડલાઈન ડેટેડ મેડિકલ થેરાપી તો છે જ બંનેમાં. બંનેમાં.
the thing is PCI plus medical therapy or only medical therapy?
હા એટલે બંનેમાં ગાઈડલાઈન મેડિકલ થેરાપી તો છે દેટ મીન્સ સ્ટેટિન તો હશે જ ને.
બેઝલાઈન કેરેક્ટરિસ્ટિક છે બેઝલાઈન ડાયગ્નોસિસ.
हाँ मतलब first initially including the subjects को कितना mean आना चाहिए. But the study is अच्छी है. PCI plus not only PCI. क्योंकि PCI which is 6 to 12 months to dual active therapies आपका आना चाहिए. The anatomic characteristics जो था they were equally divided. MLA based on minimal human area, 97% was
પેલામાં 120 30 એવી it's like that, right?
Like composite में कोई difference નથી આવતો ખાલી 2 year follow up જે છે સર એમાં થોડું vast difference 8.4 to 3.4 but long term duration 7 years ના follow up માં come to 6.5
But that is obviously expected કારણ કે તમે drug allergy strain મૂક્યો છે dual anticoagulant પેલો antiplatelet આપ્યા છે right so obviously એમાં event થતા બી આવી છે that is an
that
issue
is exactly
0.4% is an issue there
still it should have been reduced but
it should be absolutely zero
individual components of the primary composite output. So again, same mention 2 years per it is 0.4 and 3.4. Death from cardiac causes. Death from cardiac causes માં भी equivalent થઈ જાય છે PCI ને એમાં. ખાલી target vessel related MI at 7 years it is a difference like 1% and 1.4%. Not a major vast difference, but primary composite. Ischemic driven target vessel revascularization, there is a difference. At 2 years, it is only 0.1% compared to 2.4% for medical therapy. Continue with 7 years follow up also. The ischemic driven 4.9% to 8.0%. This is 1 point data primary. Rest mostly ratio remains the same. This is the individual components coming from secondary endpoints. They were mutually same to it over the changes these are even for non-target vessel revascularization same percentage. For MI also it's nearly 1% to 1.5%. So secondary endpoints there was not much major difference between both the therapies.
it is very interesting પાછળ
Yes.
non-target vessel MI 7 વર્ષે 10 અને 11 થઈ ગયા છે હવે આપણે જે ટાર્ગેટ પાછળ પડ્યા હતા એ સિવાય બીજી આર્ટરીનો MI બી આવી ગયો તમે બે ટ્રીટમેન્ટ કરો છો તો that is આનો શું મતલબ
In secondary endpoint there is nothing beneficial.
જાતે છે જાપાન હોગે છે
So they have only mentioned based on the primary outcomes which they have achieved.
yeah but if you think laterally it questions our treatment
Yes.
કે જે પેશન્ટ જેને MI મતલબ તમારું કોરોનરી ખાલી 50% ને વલ્નરેબલ પ્લેક્સમાં ટ્રીટમેન્ટ આપી રહ્યા છીએ એ નળી તો બિચારી જેવી છે એવી પણ બીજી નળીનો એટેક બી આવી ગયો એટલે તમે ટ્રીટમેન્ટ ઓલરેડી આપો છો જેમાં વધારે પેલું હતું
This yes. Again, different extent of scapulae thrombosis, not major difference. Stroke ma bhi whenever dual antiplatelets jowana છે, so not big difference. Bleeding events also nearly same. So secondary endpoint outcomes had no specific outline in this. The interpretation they had given was the result of this trial suggests that PCR focal non-FFR positive tracts that are angiographically more than 50% stenosis and have evidence of vulnerability on intravascular imaging along with OMT superior to OMT for clinical outcomes at 2 years among patients with predominantly stable IHD. And the majority of the benefit was driven by a reduction in subsequent revascularization, including ischemia-driven target vessel revascularization. So only the primary outcomes they have mentioned, and that also specifically for 2 years. On follow-up, the difference does not stay at that level.
benefits were क्या sustained at 7 years old
So only minor, 6.5 to 9.4, but that is what they have given as a recommendation.
so what are current guidelines suppose if a stable angina patient નો તમે એન્જિયો કરો અને 50% આવી in conventional angiography will you go for all these matlab you try to see the vulnerability of that plaque
Yes, but
You do, I
not
guess.
every day I just OCT3 negates.
and you why you are not doing cost only કે બીજું કઈ
Cost.
ખાલી cost otherwise કદાચ તમારું કે મારું હોત તો આપણે કર
Yes, sir.
okay
FFR at least US based.
Another thing is the vulnerability plaque in different vessel region. That left main marker. Suppose left main, vulnerable plaque is there in the left main.
It is
And
a
it becomes an indication chemical in that.
should undergo intravascular imaging, and if there is one little black, one should consider stenting.
So what is the level of recommendation in class of
These are not included. It is just
Not included?
Not included. It is just presented in clinical trials.
But see, if you want to avoid all these untimely events, this has to be done in every patient.
Yes, so that is
So
what
at
I
least
said.
teaching institute must follow this guideline. કારણ કે તમારે પ્રાઇવેટમાં તકલીફ પડે, આયુષમાં તો આવે ને, બરોબર, પણ ટીચિંગ ઇન્સ્ટિટ્યૂટમાં આ વસ્તુ સ્ટ્રિક્ટલી ફોલો થવી જોઈએ, તો આપણું ઇન્ડિયન રજિસ્ટ્રી ડેવલપ થાય.
At the end of the presentation, it was that we need to put forward that idea. All these patients should, like the guidelines should suggest that all these patients should undergo intravascular imaging and should be treated in such manner.
એ લોકોનો તો આ તો હજી એશિયાનો ક્રાઇટેરિયા છે, પણ એશિયાની ડેવલપ કન્ટ્રીનો ક્રાઇટેરિયા છે. આપણા કન્ટ્રીમાં શું કરવાનું? આપણામાં જો એવું કહી દે કે સ્ટેબલ એન્જાઇનામાં જેમાં 50% વાળું આવે, 50-70% બધાનો આઈઓસ ઓસીટી એફએફઆર કરવા જાઓ, ઉઆપો મચી જાય. અને એને એમઆઈ છે એનું નથી કરતા આપણે.
The limitation they had mentioned was that it was open label, so there were chances of introducing risk of placebo effects and ascertainment bias. The observed rates of primary outcome were substantially lower than expected in both the groups. The selection imaging modality to assess plaque vulnerability was left on operator discretion, so chances of bias were there. 9% of the preventive PCI and 1% of OMT alone group had crossed over, and the study did not collect data to examine the cost effectiveness of PCI. And DAPT use was, dual antiplatelets were given compulsorily in preventive PCI.
છે જે PCI નો કોસ્ટ ઇફેક્ટિવનેસ છે, આપણે તો સાલું ટ્રીટમેન્ટ વાળામાં કોસ્ટ ઇફેક્ટિવ નથી રહેતું, આ તો પ્રિવેન્ટિવ PCI. બટ તમને તમારા ડિઝર્ટેશન માટે સ્ટડી માટે તમને કઈ ફંડ મળે છે થર્ડ પાર્ટી કે એવું કઈ નથી મળતું? તો ટ્રાય કરજો, ICMR ના ફંડ્સ હશે. So those who are enrolling in first year, they should do all these studies. ICMR નું extramural component છે, એમાં તમે એપ્લાય કરશો કે મારે આ સ્ટડી કરવું છે ને they found the study is good, they will sponsor you n number of પૈસા. તમે ખાલી તમારું બજેટ મોકલવાનું કે 3 વર્ષમાં હું આટલા પેશન્ટ કરું, આટલા પેશન્ટના ઓસીટી આઈવસ આ કરું, તો એક બજેટ તમારે CA પાસેથી બનાવીને મોકલો, અને if they found it valid, they will fund you. And you can do this study in your own patient. તમારા ટીચિંગ ગ્રુપમાં મૂકો. ICMR બહુ સ્ટ્રોંગ
આ સ્ટડીની અંદર જે લોકોએ 7 વર્ષ સુધીનો પેલા વલ્નરેબલ બ્લોક નવા ડેવલપ કર્યા, એ લોકોને રિવાસ્ક્યુલરાઇઝેશન કેમ ઓપન કરે?
Sir, non-target vessel revascularization भी कर.
करिए, sir.
Concept is कि sir, if I'm preventing, and what the patient is already on dual antiplatelet, so now actually generate.
થયા કેવી રીતે? પ્રશ્ન જ ત્યાં છે.
અને થયા તો તમે પ્રિવેન્ટિવ PCI કેમ ન ઓફર કરે?
ના પ્રિવેન્ટિવ થયા તો એ તો સર પછી ખબર પડે ને, એટેક આવ્યો પછી
કેમ 2, 3, 5 વર્ષે કર્યા કરતા હતા ને વલ્નરેબલ પેક માટે લોકો?
ના ફોલો અપ કરતા હતા, પીસી પાછું એન્જિયોગ્રાફી ના કરે,
Imaging
ના થાય.
define કરવા માટે.
એ તો બહુ હાઈએસ્ટ લેવલનો સાયન્સ થઈ જાય, પછી એટલું તો કોઈ ના કરે ભાઈ.
નહીં તો પ્રિવેન્ટિવ PCI તરીકે ઓફર કરવું જોઈએ તો થાય જ નહીં.
પેશન્ટ બી અલાવ ના કરે ને આટલું
So
બધું.
that is a
દર
question that દર વખતે every 2 years I cannot go for imaging and get my vulnerable plaque stented. It should
તમારી રેડિયલ આર્ટરીની હાલત શું થાય? તમે 7 વર્ષમાં 5 વાર તમે ઇન્ટ્રાવાસ્ક્યુલર ઇમેજિંગ કરો તો રેડિયલ આર્ટરી ના પડે કે અમે આ બક્સ દો ભાઈ. પછી કે આ એક્ચ્યુઅલી એમાં આવે ત્યારે તમારી પાસે એક્સેસ જ ના હોય.
That is it, sir, to provide novel insight into the role of preventive PCI.
But આ વસ્તુ is required so much of discussion, right?
Yes, there are